It's a little bit easier, I think, sometimes, but on trial, that's not always feasible. I get that. So that kind of gets me to my next question: repeat GAE. All right, Oz, you get no. Sid, you get yes, and yes, and when, I will say. Oz, why don't you start? You don't offer repeat GAE. That's what I'm saying.
Yeah, I mean, again, full disclosure, I do offer it, but I think, so arguments against repeat GAE would be, if it didn't work the first time, why is it going to work the second time? Now, I think arguments against it really are, again, more pragmatic. It's like, it's hard to convince patients to undergo another procedure if they didn't perceive that the first one didn't go as well as they wanted it to. Really, the only scenario that I would see is, okay, you did, you were in, you were that patient that got that 2-year dramatic improvement, and then the pain came back. That patient's, that makes sense to do it for them. But to do it at 6 months, if you say, oh, you got a little bit of improvement, I don't know how you could convince that patient. At least in America, I feel like it's hard.
I wouldn't even try to convince them. I think if it didn't work the first time, we don't offer it again, because that makes no sense to me to try it again. Unless the rare case where you go back to your angiogram, you're like, you know what, I missed something, right? We're all human. We make mistakes, right? It'd be like, I actually had that in my very second GAE. I forgot. I didn't think about how high up the descending genicular artery comes off, right? Because you have to realize it comes off like right near the adductor canal. And I did my angiogram from the popliteal artery and I missed it, right? And he had medial knee pain. And so I was like, you know what? I think I may have missed that. So I brought him back and I did find it. But other than that, if it didn't work, I don't offer it again. I think that's wasting people's time. If it worked, just like Oz said, like, let's say they got a great response and it came back, I'll offer it again. I don't tell them to get it. I say, look, it's an option that if you want to get it again. We've done about 20 repeat GAEs, and our clinical success after the second one is about 50%, give or take. Okay, so probably a little lower than the initial success rate, but not zero. So, we offer it. I tell them, like, anecdotally, look, it's 50-50. It's up to you if you want to get it done again.
What about response out to 9 months? I'll pick an arbitrary number. Response in 9 months, out to 9 months, and then recurrence of symptoms. Would you offer it again?
I mean, if it's a significant response, yeah, I'd probably offer it again. Yeah, I mean, and we're looking for home runs. Remember that, Covey. We're not. Someone goes, I got a little better. Like, their pain went from an 8 to a 6. I don't care. That's placebo.
Okay.
I don't care. Okay. I mean, it's just nonsense, right?
That's a great point.
Normal variation, probably.
Yeah, and I would say my big criticism of a lot of the publications is when we start looking at mean WOMAC scores decreased in 20%, nobody cares. Like, that's a joke, right? Like, that makes no sense. It's not clinically relevant. There's these things called MCID, or minimally clinically important difference. That's also a joke. Like, that's not based in reality. A patient does not care if their WOMAC goes from 50 to 40. They don't feel better. We're looking for, the nice thing about this is we're looking for home runs, and we can get that. We can get that in a certain percentage of patients. So we should strive to get, you should see a significant, massive reduction in pain and improvement in your function. So if someone gets that and it recurs at 9 months, I'm totally fine offering it again.
As I assume you're the same.
Yeah, I mean, I think it's basically what Sid said is if it truly worked, right? Like, it's not if it somewhat worked. If it truly worked and they truly had a benefit and it came back. I think the caveat is I remember originally reading like Yuji's papers, and they would like almost routinely give it to people at like 3 months, even if it didn't work. And I remember asking him, I was like, how are you getting people to like repeat a GAE at 3 months?
Sure. Yeah.
When it didn't work first time? I mean, the Japanese population is probably much more
compliant.
Compliant with their physician recommendations or trusting of their doctors than I think the American.
But Oz, let me ask you this. I want to see if your experience is the same as mine. Like, when you initially started your first few cases, right? Those patients where they're like, yeah, I got a little better, Dr. Ahmed. Didn't you think that was a home run at the time? And you're like, oh yeah, it worked. Like, you're like subconsciously telling yourself, yeah, I think it worked. It's BS, right? Like, this total nonsense. It didn't work.
Totally.
It did not work in those cases. When you have a patient who are like, I can walk 5 miles and I haven't been able to do that in 20 years. That worked, right? Like, it's hard to, right? Or I play pickleball for 3 hours a day, and before I could play for 20 minutes a day. Those are home runs, right? And so that's what we need to strive for.
Yeah. Anytime they hesitate when you ask them how you're doing, it's like, they're trying, like you said, trying to please the doctor. Like, it's not throbbing anymore. I'm like, hey, that's not the goal.
Yeah,
here.
I don't need to inject fentanyl at home in my arm to get rid of the pain anymore. So that's success, right? Yeah.
All right. Two last topics, and then we'll close out. Post-TKA, I know there's some press about post-TKA. Resorbable versus permanent particles. As I'm going to give you resorbable, said I'm going to give you permanent particles.
So let me just go over the post-TKA. I think it's, after you get a total knee replacement, there's, depending on what paper you look at, 10 to 15% of patients who do not have a good result, and by meaning that they have recurrent pain. So can this be used to address that subset of patients? And I would say this is a work in progress. There is no answer as to whether this is going to work in those patients or not. I think right now it remains unanswered. I think the challenge is to pick the right patients. I think picking the right patients is actually even harder than picking someone who has never had a knee replacement, because you have to exclude a lot of other stuff. Do they have, for example, pain radiating down from their lower lumbar spine? Is it due to their prosthesis? Is it due to scar tissue? Is it due to adhesions? Is it due to loosening? Is it supratentorial, right? Like, because but you don't have access to psychometric testing. All those reasons, GAE is not going to help, right? And so I think the challenge, we tried this initially in 5 patients and as a pilot, and we did not succeed. We failed. And I think in retrospect is that we did not have a thorough selection process. Our selection process was just not good enough, right? So I think if you can come up with a good selection process, this is a great topic for study.
I think, we talked about this way back, I think 2020, 5 years ago now, at the research consensus panel of like, who's the ideal target patient population for GAE. And I think there was a argument to be made for TKA patients because these are people who really, once you reach that point of post-TKA pain, there's nothing really left. There's kind of these nebulous things that, like Sid has just mentioned, like loosening or scar tissue, or they kind of just tell you that you're crazy or whatever and just, figure it out. The reality is, I think the reason why we didn't choose that as the sort of population to try to validate GAE is because of what Sid just said, which is there is a lot of stuff going on, and the patient selection criteria probably would leave you with such a small population that would be eligible for this, that it would be really hard to realistically sort of do studies, of high sample size that you could actually give you meaningful data. So is there a role? I think there is a role, but as far as I'm aware, there's just one pilot study from France on this. So we definitely need more data. We need strict inclusion criteria. And as far as the embolic of choice for that's probably, number 25 on the list of things we need to do before we
But I would love to see just even if there was like a multi-center, single arm, 50 patient study where, you had a bunch of orthopedic surgeons say, come together with inclusion and exclusion criteria. I think that can be done. It would be hard to do randomized. I think that's obviously another, kind of a barrier. But even just start with a 50 patient single arm, I would love to see something like that.
Yeah, and I think that's the only way to probably do that right now is that exact approach that you just talked about.
Yeah, because at the very least, before you do an RCT, you'd want to see if there's a signal, right? Like for all you know, there's no signal, then stop wasting your time doing an RCT.
I just want to point out, I love the fact, not all these questions are meant to be simple and straightforward. They're meant to be kind of discussional and thought-provoking. I love the fact that neither one of you answered that question, and we went completely off topic. But that was great. I think that's super, super valuable.
One of the things you discover about doing this, the more of these procedures I do, I feel like I understand it less. I have more questions than answers every few months on musculoskeletal embolization.
I think that is replicated in a lot of spaces, not just MSK, right? But yeah, go ahead, Oz. I'm sorry.
No, go ahead. I forgot what I was going to say, actually.
Yeah, it's a challenging space, right? I mean, everything experience adds to everything, to your point, Sid, and we are learning day in and day out, right? So specifically on this topic, we get a lot of consults for effusion and hemarthrosis post-TKA, but is there relevance for just pain without in that? And maybe there's not, to your point, but